All right, good morning, everybody. I'm not going to make everybody say good morning. We're not all as peppy as me at this hour. I'm a morning person. You'll see a considerable drag when I come back in the afternoon. Anyways, my name is Doug Gould. I'm a professor and chair of the Department of Foundational Medical Studies at Oakland University William Beaumont School of Medicine. Not the longest medical school name in the country, I am told, although it's got to be pretty close. We're one of the new cadre of the 14 newer medical schools, with Florida State being probably the oldest of those. We're a little bit outside of Detroit, about 17 or 18 miles north of the city of Detroit, for those of you who don't know where it is. The school is divided fairly traditionally. We have what I call a hyper-integrated curriculum. But the basic sciences are housed at Oakland University, and all our clinical curriculums at our clinical partner, Beaumont Health, which is a little bit outside of there in Royal Oak. But I have been teaching neuroscience, neuroanatomy mainly for about 25 years, and this is my fourth year here. So doing the Osler lectures. So I think I'm with you for 4 hours this morning, and then I have a break, you guys know, and then I'll be back for my final 3 hours later this afternoon. That's when you'll see the drag, but that's okay. Nice that I have a nice break in there. My task is to cover neuroanatomy, and I'm setting the groundwork. I look through your schedule for everything yet to come is the way I look at it. You have brain and spinal cord trauma. We're going to go through brain and spinal cord anatomy. You have stroke. You have peripheral neuropathies. You have ophthalmology issues, psychiatric movement disorders. I'm going to do the anatomy for all that. I'm going to try very hard to stay in my lane, as we say, and not venture too hard into other people's thunder. Sometimes that's not possible, but I'm going to try to stick to an overview in 7 hours of all the anatomy of your nervous system. If you have any questions or thoughts, please feel free to stop me. I usually go a little bit behind during these first few, but we will be caught up probably by the noon hour, if not certainly by the end of the day. Okay? Does anybody have any questions? So the first thing we're going to talk about is peripheral nervous system, and we're going to go through the structure of a typical spinal nerve. We're going to talk about the types of fibers that can be found in a spinal nerve. We're going to talk about plexuses, why we have them. We'll talk about dermatomes versus patterns of cutaneous innervation as a diagnostic tool. We'll talk about referred pain a bit, and that should wrap up peripheral nerve. I guess I could have gone to this slide. It has everything I just said on it. So. If there's anything else, I think it's good practice to say if there's anything else y'all would like to discuss, I can do my best, although we won't have PowerPoints on it. But so one of the things I emphasize to medical students, I teach the first year and second year neuroscience courses at my school. I teach the fourth year anesthesiology, pain. The anesthesiology related to pain. For the fourth year students, I do some residency teaching. I always emphasize this concept. I think we get hung up on labeling nerves or thinking the vagus nerve, for example, is a parasympathetic nerve. No, it's not. A very small percentage of the fibers in the vagus nerve are parasympathetic. It's a sensory nerve if you feel the need to put a label on it. 75–80% of its fibers are sensory. So I think it's important to emphasize that a nerve is just a collection of axons, and we shouldn't get hung up on labeling it. You need to know what's in there, but I like to compare it to a highway, right? It's a highway. We care about the direction the cars are going. We care about what cars are on that highway, but very rarely will you label a highway, this is a one-way road with only red sedans on it. It just rarely happens. A little bit in the case of the cranial nerves, which we'll talk about, but we're gonna try to emphasize that point as we go through the day today. Okay, so your periphery, the body, is connected to the central nervous system by cranial and spinal nerves, right? If it's not a cranial or a spinal nerve, or a ganglion somewhere out in the periphery. It's central nervous system. We're going to do that in the next hour. We'll go through 2 hours worth, and then we'll take a break. Okay? I should say, if you guys want to use the restroom or something, please feel free. I won't be offended. Nerves can be myelinated or unmyelinated. We'll talk a little bit about that. We have 12 pairs of cranial nerves, 31 pairs of spinal nerves, and they're divided out as such. So this is a picture we'll linger on for a bit. This is a transverse section through some idealized section of the spinal cord. We know that this must be between T1 and L2 spinal cord levels because it has a lateral horn, right, made up by the intermediate lateral cell column. Anterior horn, posterior horn. You can say ventral or dorsal. I'm a big fan of giving us credit for being bipedal. So I always say anterior and posterior. And let's label some of these things. I think they're labeled a little bit later. This is the anterior root or ventral root or motor root. This would be your posterior root, your dorsal root, or your sensory root. This little guy right here is the spinal nerve, just that little bit. And that's the part that you would find in the intervertebral foramen. It would be leaving the vertebral canal. This part is often impinged if you have a little bony growth here, the spinal nerve. These roots are what are affected mostly if you have something like a herniated disc. It's the roots that are going to be impinged, and that's why a lot of times you'll have either motor or sensory problems, depending on where the location is. Then when I get out here in the periphery, I have rami, branches, posterior and anterior rami. This is supposed to be a little abstracted hunk of sympathetic chain or paravertebral chain. I think I did. I brought my analog pointer. Only time of the year I get to use this bad boy. So there's the sympathetic chain. This I'm going to label a little bit later as a prevertebral ganglion or a preaortic ganglion. We'll talk about that. That's just some little hunk of gut or some bit of viscera. So in the anterior horn, I have somatic motor neurons and interneurons. But this is the location of my somatic motor neurons. Somatic is telling you that this is going to control the body or the body wall. Somatic motor neurons send their fibers out, the anterior root. They pass through the spinal nerve and out to the periphery, to the back or to the more anterior aspects of the body. Going to cause contraction of the biceps brachii, for example, or contraction of the diaphragm, conscious contraction of the diaphragm. These neurons don't function in isolation. We're going to spend a fair amount of time today talking about who's the boss of these neurons. They mainly work reflexively, right? I think a lot of novice learners think that these are always consciously controlled. I would argue that they're almost never consciously controlled, right? They're mainly working reflexively or from higher unconscious centers. We have sensory neurons coming in the sensory or posterior root, and these fibers enter the dorsal horn or the posterior horn of the cord. Note the difference in the location of the cell bodies. Inside the CNS for the motor neurons, in the peripheral nervous system, in this ganglion, they go by a variety of names: dorsal root ganglion, posterior root ganglion, or spinal ganglion. Any of those are appropriate. And these would be fibers, say, coming in from my forearm, a bee just stung me or something, and those fibers travel in through this anterior ramus, through the spinal nerve, through the posterior root, and into the spinal cord. And we'll talk all about what happens once it gets in there. So far, my spinal nerve has two things in it: somatic motor fibers and somatic sensory fibers. Okay. We have other types of sensation. We're going to talk all about this when we talk about the sensory system. But not only do I have somatic sensation, somatic sensation is specific and well localized. And what I mean by specific is you can grade in intensity. It hurts a 7 out of 10. It's a sting or it's a burn. You can give really specific information about that sensation. It's well localized. That bee is stinging me right here. But a ton of the sensation in our body is not so. It's visceral sensation. Viscera is telling you it's coming from a hollow organ. That sensation is mainly based on stretch receptors in the gut. It is poorly localized sensation. It is not specific. I can't say I have a stomach ache right here, and I'm putting it on a 7 out of 10, it's a burn. It's, I don't feel good here. It's poorly localized sensation. Nonetheless, all sensation, regardless whether it's somatic or visceral, all sensation has its primary afferent cell body in the periphery, in one of these dorsal root ganglia or spinal ganglia if it's from the body, or in a comparable or homologous ganglia in the head if it's for the face. And we'll talk about that in a bit. This sensation takes kind of a strange route. It's coming back from this organ. It comes on through the prevertebral ganglia, through the aorta, up through the sympathetic chain. We're going to do all this later. Up through this little branch, this little communicating branch. It's myelinated, so we call it a white for the myelination. Rami, it's a branch, communicans. And it comes up through the spinal nerve and synapses on similar population of fibers in the posterior horn. So far, my spinal nerve now has visceral afferents, somatic efferents, or motor, and somatic afferents. So for now, I'm comfortable intermingling the terms sensory and afferent, motor, and efferent. That's all going to change when we get into the central nervous system. It's a little bit sloppy the way I'm saying it right now. I'll tighten it up when we get into the central nervous system. It's very clear that if information is coming in from the periphery, I can call it sensory. If it's coming in towards something, I can call it afferent. Once we get into the CNS, you know, something that's efferent to me may be afferent to this gentleman here. And it depends on a matter of perspective once we get into the central nervous system. So for now, I'm being a little sloppy with it. This lateral horn is a cell column called the intermediate lateral cell column. It's made up of preganglionic visceral efferents. In this case, there's so many of them, they form a lateral horn. And that is the location of the preganglionic sympathetic neurons. We'll talk all about that with the motor system. They're motor. They're visceral efferents. That means they have to send their fibers out the anterior root. Now we're going to worry about where this thing goes later today. But suffice to say, its fibers come out the motor root, pass through the spinal nerve. Note it does not go to the periphery directly, rather it leaves the spinal nerve via the white rami communicans and enters the sympathetic chain. And they do this 100% of the time. We'll talk about it later. But now my spinal nerve has preganglionic visceral efferents, somatic efferents, and visceral and somatic afferent fibers. So I have 4 fiber types in that spinal nerve. This, we'll talk about this briefly. In this case, and there's other possibilities, that preganglionic is telling you there's a ganglion. And a ganglion is an accumulation of neuronal cell bodies outside of the central nervous system. Doesn't tell you much about it, but this is a ganglion, and this is a ganglion. They're both accumulations of neuronal cell bodies outside the central nervous system, right? Doesn't give you any information on who's in there or whether there's even synapses in there. There's no synapses in this ganglia, and there's lots of synapses in this ganglia. So there's big differences. It's a very limited definition. But I enter the sympathetic chain as a preganglionic, and oftentimes, if I'm going to the body wall in particular, visceral targets in the body wall would include wonderful things like the erector pili muscle, right? Smooth muscle that makes goosebumps. Vasoconstriction of the blood vessels is sympathetically mediated, and sweat glands are sympathetically mediated. So these would be the 3 big body wall targets. We'll get to them later. Anyways, the synapse occurs here, and this postganglionic fiber sends its neuron sends its fiber back up this gray or unmyelinated communicating branch and back into the spinal nerve for distribution to the body wall. I have a lot of possible fibers.